So this is Module 51, Dissociative Personality and Eating Disorders. So this is a kind of a grab bag of disorders, and it's the last in our series of our discussion of psychological disorders or psychopathology. So some of the other disorders that we haven't talked about yet are dissociative disorders, eating disorders, and personality disorders. We also have things such as substance abuse disorders that we are not going to be talking about in this course, but I would strongly encourage you, especially if you're continuing on in psychology, to take abnormal psychology, which I think if you enjoyed these lectures, you'll find absolutely fascinating. So dissociative disorders first. So dissociation, if I could speak properly, refers to a separation of conscious awareness from thoughts, memory, bodily sensations, feelings, or even identity. So what does all that mean? You probably know it more under the name of multiple personality disorder, or dissociative identity disorder. But there are a whole bunch of other dissociative disorders whereby somebody is somewhat detached from the reality of their body in a different way from schizophrenia. So it can also serve as a psychological escape from an overwhelming stressful situation. So you can see memory loss in dissociative issues. So that's when you see on TV when somebody comes from a different town and they have no recollection of who they are or where they came from. So that's known as the dissociative fugue. Something very traumatic has happened, the person has left and they don't have any recollection. So a dissociative disorder refers to dysfunction and distress caused by chronic and severe dissociation. So we have dissociative amnesia, where you can actually forget things. The fugue, as I mentioned, where you kind of go into a different place and assume a new identity. And then dissociative identity disorder, DID, or multiple personality disorder. So that's just what I explained to you. These are often always caused by some severe stress that our mind cannot handle, and so this dissociation takes place. So the most popular of these dissociation disorders is dissociative identity disorder or multiple personality disorder. And as you see at the bottom from the Three Faces of Eve, you've probably seen the movie Sybil at high school. This is just made for movies and the TV. In actuality, there are very few cases of DID. In the cases that do exist, the personalities are usually distinct and they're not present in consciousness at the same time. So people are not, the child and the promiscuous woman at the same time. These personalities may or may not be aware of each other. So what is speculated, and there's a big debate in the literature, is that DID really doesn't exist, and that it's kind of, the person isn't doing this, on purpose, but it's kind of a developed disorder and a way of coping. And it's kind of an extreme form of role play, but the person is not doing it on purpose. As I said, it's in people who are very traumatized and often have poor coping resources. It actually might be a recent cultural construction, kind of similar to the idea of being possessed by spirits. And cases of DID might be created or worsened by therapists encouraging people to think of different parts of themselves. There's actually been some evidence that there are certain therapists across the country that have caused this disorder in their patients because they're kind of hubs of this disorder. They all seem to have seen similar therapists. Is DID true or not true? I mean, it is true in the sense that the patient believes that this is happening to them and the patient has these real experiences. Does the patient actually possessed by multiple personalities? The reality is probably not. They do find that the different personalities have different brainwave patterns. There's different left and right-handedness. There's different visual acuity and eye muscle balance patterns. And patients with DID also show heightened activity in areas of the brain associated with managing and inhibiting traumatic memories. So according to the psychoanalytic perspective, DID can be caused by a diverting id. Cognitive perspective is somebody coping with abuse. The learning perspective is that there's rewarding component to dissociation, and from the social perspective, the therapists encourage this. So if you're interested more in DID, there's some articles I can refer you to, so that if you want to read some journal articles where the debate is discussed, you can send me an email and I'll send those to you. So now we're going to move on to eating disorders. And the most known of these are anorexia nervosa, bulimia nervosa, and binge eating disorder. So These disorders may involve unrealistic body image, an extreme body ideal, a desire to control food and the body when one's situation cannot be controlled, cycles of depression. So depression is comorbid oftentimes with eating disorder, and problems with health. So anorexia nervosa is a compulsion to lose weight, coupled with a certainty about being fat despite being at least 15% or more underweight. Previously, you had to have stopped menstruating if you had started already, that you've lost so much weight that you cannot have your period anymore. Less than 1% of the population will meet criteria for anorexia nervosa at some point during their lifetime. There's people in certain professions like ballet, gymnastics, who might have higher prevalences of this disorder. Bulimia nervosa is the compulsion to binge, eating large amounts of food quickly and then purging by losing the food through vomitings, laxatives, and excessive exercise. People who have bulimia nervosa tend to be slightly overweight, but they also are very dissatisfied with their body image, and it's about 1% of the population reports having bulimia nervosa. Binge eating disorder is basically bulimia nervosa without the purging behaviors, and so these people are usually overweight and sometimes obese, and this happens in about 2.8% of the populations. So what are some of the things that can cause eating disorders? There are family factors like having a mother focus on the weight or her child's appearance and weight, negative self-evaluations in the family, so viewing, mothers, sisters, etc., talking about how fat they are, how they're unhappy with their shape or body. For bulimia, if childhood obesity runs in the family, sometimes this is a reaction to being made fun of or mocked in childhood. For anorexia, families are competitive, high achieving, and protective. You'll see higher prevalence rates. Cultural factors are unrealistic ideals of body appearance, and so, in our culture, we very much value skinny women, and we see them as somehow superior to women who are more rotund. If you see the image on the right, that's what a model looks like, relatively emaciated, and that's considered what we see as beautiful. Moving on to personality disorders, these are enduring patterns of social and behavior that impair social functioning. So these are not necessarily disorders per se, but these are ways that people were born and they interact with their environment. So these are not things that come and go, but they're relatively stable. And there are 3 general clusters of personality disorders, and there are several under each of these. The first one is the anxious personality disorders. This is different than anxiety. These are people that are just generally anxious by nature. So avoidant personality is one of these. There's the eccentric odd personality disorder. So these are people who have kind of flat affect, no social attachments along the schizophrenia type. Schizoid personality disorder is one of these. And then there's the dramatic personality disorders like histrionic, narcissistic, or antisocial. So antisocial personality disorder, you may have heard about this because it's often a diagnosis that people in the criminal justice system receive. But it refers to acting impulsively or fearlessly without regard for others' needs and feelings. And the diagnostic criteria include a pattern of violating the rights of others since the age of 15, and include 3 of these: lying or deceitfulness, disregard for the safety of self or of others, aggressive behavior, failure to conform to social norms, lack of remorse, impulsivity and failure to plan ahead, irritability, irresponsibility regarding jobs, family, and money. So you'll see that many of these criteria, do meet, are, common among offending populations, but not necessarily that they meet diagnostic criteria. So which kids may develop antisocial personality as adults? So you cannot be given the diagnosis of APD as a child. You would either have, if you have kind of acting up behavior, you would have conduct disorder or oppositional defiant disorder. About half the kids with persistent antisocial behavior develop lifelong antisocial personality disorder. So who are the kids that are at risk? Those who in preschool were impulsive, uninhibited, unconcerned with social rewards, and low in anxiety. Those who endured child abuse or inconsistent available parenting or caretaking. And there are also some biological traits. So there's some association that there's some genetic heritability. And then risk factors include body-based fearlessness. So people who have, they can do, you'll see the kids that are jumping around without any fear. Lower levels of stress hormones, and low physiological arousal in stressful situations such as awaiting or receiving a shock. Fear conditioning is impaired, so they don't fear heights as much as some other kids do, and they have reduced prefrontal cortex tissue activity, which leads to impulsivity. You'll also see substance abuse and dependence, which is more likely in these individuals. But antisocial personality disorder does not necessarily equate to criminality. There is an overlap, obviously, as you see with this Venn diagram. But we have people who are criminals who do not have ASPD, and we have people who have ASPD who are not criminals. So we do have a lot of criminals who do show empathy and selflessness with family and friends. And most people with APD do not commit crimes. So more broadly now, how common are psychological disorders? As you can see from this bar graph here, that the prevalence of psychological disorders vary by country. I would venture to say, I don't know the methodology of this study, but that this is largely a factor of diagnosis and symptom presentation, and that sometimes that we do not here in America have nearly, that many more times the mental disorders as those in other countries, including serious mental disorders. However, there are cultural factors which is also evidenced here, both in reporting and diagnosing of symptoms. So these are the list of past year prevalences of various mental health diagnoses in the United States. So GAD we see 3%, social phobia 7%, specific phobia is 9%, mood disorders 10%, OCD 1%, schizophrenia 1%, PTSD 3.5%, ADHD 4%, and the percentage of people in the last year who are reporting a psychological disorder in the US is 26%. So 1 out of 4 people has a psychological disorder this past year in the US, which is kind of scary. And a good reason to get into the mental health field, because definitely people do need our help. Here's the list of common risks for mental disorder, as well as protective factors. So you want to have more of the things on the right and fewer of the things on the left. Some of the things that obviously you can't control, like low birth weight, medical illness, parental mental illness, but you can do a lot of the protective factors like aerobic exercise, literacy, working on your problem-solving skills, working on your self-esteem, working on your social and work skills, getting social support. So those are all things that you can work on even if you have a lot of the risk factors.